Good morning, and thank you for joining today's webinar. I am Dr. Audrey Merriam, and I am a maternal-fetal medicine physician at Yale University, and I am currently a member of the Education Committee with SMFM. I would like to welcome everyone to the SMFM webinar on management considerations for COVID-positive pregnant patients, presented by Drs. Torre Halscott, Jason Vaught, and Sindhu Srinivas. Torre Halscott is a maternal-fetal medicine specialist and critical care doctor who treats patients with high-risk pregnancies in the Baltimore area. He is an assistant professor in the Division of Maternal-Fetal Medicine in the Johns Hopkins University Department of Gynecology and Obstetrics. Dr. Jason Vaught is a board-certified maternal-fetal medicine specialist and surgical critical care physician at Johns Hopkins Medicine. His focus is in the discovery of treatment and therapies in HELLP syndrome, decreasing severe maternal morbidity, and cardiovascular disease in pregnancy. Dr. Sindhu Srinivas is an associate professor of obstetrics and gynecology, director of obstetrical services at the Hospital of the University of Pennsylvania, and vice chair for quality and safety. As an obstetrician gynecologist and maternal-fetal medicine specialist, Dr. Srinivas is clinically active in all aspects of MFM care. She is deeply committed to improving health outcomes of women and children through her research, advocacy, and clinical work. Dr. Srinivas is an active member of the American College of Obstetricians and Gynecologists and of the Society for Maternal-Fetal Medicine, and is currently the chair of the SMFM Health Policy and Advocacy Committee and is on the SMFM Board of Directors. Before we begin, I would like to take a moment to share a few housekeeping notes about today's webinar. This webinar is being recorded and will be available to view on demand from the SMFM website. Following the lecture, there will be a 20-minute question and answer segment. You may enter your questions using the Q&A box at the bottom of your screen at any point during the broadcast. Please refrain from using the chat feature to ask the panelists questions. We promise to get to as many questions as possible during the time allotted. With that out of the way, let's begin the webinar.
This is Torre Halscott here at Johns Hopkins Hospital with Jason Vaught, and thank you everyone for joining us today. Greatly appreciate it. We'll try and go through everything and answer as many questions as we can. So our objectives, we want to talk mostly about the disease severity for our patients and how they're presenting, and then putting forth some management paradigms for each class of disease from asymptomatic through critical illness, and describing the indications for critical care in general, focusing on COVID patients, but we do want to talk about some general aspects of critical care in pregnant patients as well. And then lastly, we'll finish with delivery considerations for our COVID-19 positive patients. We have no disclosures. And starting off classifying the disease severity, we've broken it down into 4 groups. We have your asymptomatic, or what's being referred to a lot as pre-symptomatic patients, your mild patients who have some manner of symptomatology but are able to be managed outside of the hospital, and then going further along your severity to moderate severe, and then critical illness is an offshoot from those patients who are severely ill and need to be evaluated and managed in the hospital. And the evaluation and management is not only at the time of presentation, but really needs to be an ongoing assessment for these patients, as they can unfortunately get sick very quickly. Your asymptomatic or pre-symptomatic patients are those who are going to have a positive test without current symptoms. How that positive test comes to be arrived upon varies from institution to institution and location to location. These may be close contact exposures, household contacts, care providers, maybe admission to the hospital screening, or however this test result comes back positive. Once you have a positive test where the patient doesn't have symptoms, then they would fall into that initial category of who needs to be monitored and followed more closely. As far as the recommendations for the close monitoring for these patients, currently we're advising them to do daily self-assessments, and we'll get to the specific symptoms momentarily, but keeping an eye on if they're having stable symptoms or if they're starting to have any deteriorations, and then giving them specific instructions about when to contact their providers or contact labor and delivery or whatever mechanism each location and institution has to follow these patients up. Certainly telehealth, telemedicine is something that we've been utilizing here at Johns Hopkins. A lot of our colleagues around the nation have been utilizing as well. It's definitely a reasonable option to help continue giving patients the prenatal care that they need and deserve, while also limiting the exposures to all personnel. And the institutions really need to work on making sure they have a reliable system for not only early detection of the COVID-19 itself, but then for worsening conditions, as well as making sure these patients can remain plugged into the system. The symptoms that we're asking patients to be cognizant of, as well as those we should be mindful of when they present, certainly dyspnea and tachypnea. If they have an unremitting fever, which we've defined as greater than 39 degrees centigrade or 102.2 Fahrenheit, despite adequate Tylenol use, the current recommendation is approximately 3 grams maximum per day of acetaminophen. If they're utilizing that appropriately and still having fevers that are persisting, that's worrisome and something they should contact us for. If they're not able to tolerate hydration, oral medications, if their oxygen saturation is diminished, either at rest or at exertion, less than 95% as measured by pulse oximeter. There's some patients who will have that at home or when they present for evaluation. If they have ongoing pleuritic chest pain, certainly new onset confusion or lethargy or any altered mental status. If they have cyanosis or for the usual obstetrical complaints as well. There's not great guidance, unfortunately, about the timing and frequency for follow-up outpatient care, not only in the non-pregnant patients, but certainly in pregnant patients as well. So our current recommendation is one visit within the 2 weeks of diagnosis to ensure that patients understand what symptoms to be aware of, for us to quantify what symptoms are present and the severity thereof, and then to move forward with further observation or inpatient management if that's indicated. And as we said, this can certainly be via telemedicine, or some institutions are developing specialized COVID clinics where these patients can come in person and diminish the risk to the rest of the personnel as well as the rest of the outpatient population. OB providers certainly need to remain involved in the care, even if the COVID clinics are staffed by medicine colleagues. We need to make sure that they're aware of the complications that can arise from an obstetric, maternal, or fetal standpoint and continue to monitor them for that. We're currently recommending a 14-day self-quarantine otherwise, and then in-person follow-up for prenatal care, antenatal testing really needs to fall under each institution's specific protocols.
So going from asymptomatic to mild disease is when you have a positive COVID-19 test and the presence of symptoms. So these symptoms include cough, fever that is responsive to acetaminophen with appropriate dosing, myalgias or loss or smell or taste. It also excludes more severe symptoms like dyspnea, tachypnea, or abnormal chest imaging. When we think about mild disease, we kind of think to ourselves, well, can this be managed as an outpatient or can it be managed as an inpatient? Considerations for inpatient management would be comorbidities that put you at increased risk for developing severe disease of COVID-19. So these would be things such or risk factors such as uncontrolled hypertension, inadequately controlled pregestational or gestational diabetes, chronic renal disease, chronic cardiopulmonary disease, or being in an immunosuppressive state, whether that's an intrinsic suppressive state or an extrinsic, basically meaning you're on medications such as prednisone or tacrolimus. When it comes to inpatient management, they should be isolated in a COVID-19 area if that's possible. The vital signs for mild disease are usually every 4 to 8 hours, and the vital signs include temperature, heart rate, respiratory rate, and blood pressure. Institutions or wards or COVID units can use pulse oximetry so that they can decrease exposure to healthcare workers while still being able to adequately observe these patients in the mild disease setting. Moderate symptoms are the presence of any of the symptoms included below. This could be refractory fevers despite adequate acetaminophen use, including dyspnea, tachypnea, abnormal chest imaging, abnormal arterial blood gases, or any type of saturation, or needing supplemental oxygen to keep your oxygen blood saturation greater than 93%.
Arterial blood gases is certainly a very important item that we look at in the ICU. Less commonly do we obtain these in our pregnant patients, but I think it's very vital to understand the differences between the pregnant patient and the non-pregnant patient, not only for the patients for COVID that present, but otherwise other pregnant patients that present in extremis, as well as to be able to communicate best with our critical care intensivist colleagues. We've got the most common parameters we're looking at from a respiratory situation on the left there, our pH, our partial pressure of oxygen and carbon dioxide, as well as the bicarbonate. And in the middle column is the non-pregnant adult and the normal ranges for those. you look towards the last column on the right, pregnant patients are going to have a compensated respiratory alkalosis. They're going to have a slightly higher PaO2 in general, but a significantly lower PCO2. And that's very vital for us to remember, as well as for us to communicate to our critical care colleagues. Whether it's due to COVID or any other respiratory factor, if we have a pregnant patient that has a normal or certainly an elevated PCO2, that's something that we should be mindful of. We should try to determine why that's occurring and also communicate to our colleagues that we're concerned that they're retaining CO2. Because a lot of the medical record systems, the normal values won't show up as abnormal. They won't be highlighted in red or green or blue or whatever it may be at each institution. So if they have what looks like a normal ABG, but they're a pregnant patient, that may be significantly abnormal for them. As far as continued management for moderate disease, we believe it's inpatient is warranted. As stated, with mild patients are admitted, these should be on a COVID ward, isolated from other patients, negative pressure units as available. Can be in an intermediate or sometimes what's colloquially called a step-down area or step-down care. Vital signs, obtain these typically every 48 hours as well, with very similar parameters to the mild patients who are admitted. One caveat is these patients really should be monitored with continuous pulse oximetry. However, it can often just be recorded in the medical record every 48 hours, but it should be something that we can have a close eye on in case they do have progressive desaturations and progressive worsening respiratory status. Some of the early warning signs that we look at for patients who have moderate disease that may be progressing to severe, certainly if they're reporting an increased sensation of dyspnea or they feel or look like they're having an increased work of breathing. So if they're using their accessory muscles, they're breathing more rapidly, breathing more shallowly, those are all things as intensivists as well as maternal-fetal medicine experts we get concerned about for our patients. If they can't maintain their adequate oxygen saturation, despite us giving them supplemental oxygen, that plays into the same clinical scenario, but sometimes patients can look comfortable, but not be able to maintain their adequate oxygen saturation. And a unique aspect of COVID is we've been seeing this with some of our patients where their oxygen saturation is significantly low, but they haven't yet started to utilize some of these accessory muscles and other factors clinically that we see typically with those low saturations. Persistent or frequent fevers or worsening myalgias are also signs that their clinical status may be worsening. This is an item, the Q-SOFA score, that was advocated for in general for patients that may be getting more sick, either on the ward or even in the ICU, and has been looked at to a degree in pregnancy. None of these scoring systems are perfect, and that's true for pregnant patients as well as the non-pregnant patients, but this is a quick, as the Q for Q-SOFA stands for, easy determination for who may be getting more sick and who may need a higher level of care, including ICU level care. And these are things that as intensivists, we don't typically calculate this out, but these are the things we're looking for when we lay eyes on a patient. Are they having a low systolic blood pressure? Are they having inability to maintain their perfusion? Are they breathing quickly, greater than 22 times a minute? Or do they have any altered mental status? The Glasgow Coma Scale is a range of 3 to 15. So even something as simple as mild confusion, and they have a GCS of 12, 13, 14, we typically see that a lot of times with patients in the ICU, but that certainly would be concerning in an otherwise young, healthy patient. And those are the things that we can also utilize to assess these patients when they present, as well as communicate with our intensivist colleagues. Some supplemental oxygen strategies for patients who are having increased work of breathing: common nasal cannula, which should be readily available on all inpatient wards, with a typical maximum of 15 liters per minute deliverable from the wall supply of oxygen. If that's unsuccessful, it can be escalated to a face mask, typically a non-rebreather type, which also can increase to approximately 15 liters per minute, usually from the wall supply. However, with supplemental supplies, certain oxygen tanks, this can be increased to a relatively high rate of 50 liters per minute. That's an uncommon resource, but each institution may have that and may be something that can be utilized as a temporizing measure while other adjuncts and other support is being rallied. A Venturi face mask can look similar to a non-rebreather face mask, but functions slightly differently. It utilizes the fraction of inspired oxygen, which we typically call the FiO2, with a maximum of 60% oxygen delivery. And this may be another modality while you're waiting for other help and other interventions potentially for your patients that are having more respiratory distress. And the subsequent step between those and intubation would be your non-invasive positive pressure, things such as BiPAP, bi-level positive airway pressure, or continuous positive airway pressure, or CPAP. Another interesting aspect of care to optimize ventilation that we've been utilizing in our COVID patients is proning. There's an aspect of this known as passive proning. So these are your awake and alert, able to follow commands, non-intubated patients, and you're actually asking them to lay on their sides or to lay fully on the prone position on their stomach for approximately 2 hours at a time. And that's the typical interval where we're rolling patients from side to side if they're intubated in the ICU anyway, to decrease risk of decubitus ulcers and those things. And you can have a patient moving themselves every few hours, ensuring that they're doing that properly. And there's some emerging evidence, especially in COVID patients, that may help prevent intubation for some. This is just a quick illustration to look at those positions that can be utilized, the top three, the supine, prone, and the right and left lateral recumbent or decubitus positions.
And now we're going to transition into the severe disease. And Torre, just for what you touched on, when it comes to mild and moderate disease, there's always the discussion of, well, where does the patient go when they're pregnant? Do they stay on L&D? Do they go to the COVID unit or the IMC unit? There are some L&Ds that are equipped with COVID bio units, and that really depends on your institution and the level of pulse oximetry and telemetry that your institution or your L&D can have. But again, it's going to be institution specific, estimated gestational age specific, and also to what your L&D can provide. When it comes to severe disease, these patients are generally going to be in the intermediate care units or an IMC COVID unit. And so what classifies someone as severe disease? So it's generally being tachypnic, or respiratory rate greater than 30, being hypoxemic with supplemental oxygen. So this is someone who has 4 or 5 liters nasal cannula and they're satting 90%. Also to having a P to F ratio of less than 300, or having greater than 50% of lung involvement on imaging. So when we look at imaging, I really want you guys to kind of take a look at these x-rays. So as you can see here, there is lung involvement on the periphery, and this is not only specific to COVID, we find it in COVID, but it can be specific for any type of viral pneumonitis. As we go to the next image, you can see that this infiltrative process is expanding. And when you get to greater than 50% of this is someone who could become very hypoxemic very quickly. So you really want to make sure that they have close monitoring. So an IMC level or critical care unit is very appropriate for this patient. Transitioning from radiographic imaging from plain X-ray to CT scan, again, here, certainly less than 50% of the lung is being associated with COVID. So right here, but then again, you see this peripheral infiltrative process that it's beginning to occur. And not only peripheral infiltrative process, but now dependent peripheral infiltrative process. So again, the more severe disease, the greater than 50%, it's just something that we can look at imaging, and the higher likelihood that we think these patients can become critically ill. And this is just someone who has just what I would call fulminant pneumonitis or pneumonia from COVID-19. So again, this is someone who's severely ill or critically ill and needs a higher level of care. When we talk about severe disease, we have to talk about ARDS severity. So we've already talked about the P to F ratio or the PaO2 to FiO2 ratio. And this is classifying it into mild, moderate, and severe disease by the Berlin criteria. Mild disease is classified as having a P to F ratio of 200 to 300, moderate disease is 100 to 200, and severe disease is less than 100. To the right, you can see the mortality based on mild, moderate, and severe disease. However, I want to be clear that this is not in the pregnant population. This is in the non-pregnant population. Actually, outside of COVID or in general, the pregnant population actually has a better prognosis when diagnosed with ARDS, secondary to the fact that number one, the median age is much lower because our patients are pregnant and young reproductive women. And then number two, they have less associated comorbidities. So speaking more to severe disease, well, what does monitoring in severe disease look like? Again, these patients are in an IMC or step-down unit area. So it's usually to that specific unit. And most of these units will be doing 2 to 4 hour monitoring with continuous pulse oximetry, if not telemetry. Transitioning into critical disease, that is basically someone that is COVID-19 positive and requires critical care. So that means that the patient has respiratory failure requiring mechanical ventilation, multi-organ dysfunction or failure, so renal injury requiring CRT or dialysis, and shock, which is basically refractory hypotension with evidence of end organ damage or lactic acidosis. Intubation indications in critical disease should be individualized. I can't stress that enough. It is based on maternal clinical status, any pre-existing comorbidities, whether it be in transit to the lung, like cystic fibrosis or asthma, presence of any other organ failure or cardiovascular collapse, required oxygen supplementation, or could even be for the need to transport one patient from one location to another. Typical triggers would involve consultation with an intensivist critical care specialist or an anesthesiologist or ED provider. In general, even though we talked about O2 sats can sometimes be low and patients still be comfortable, outside of COVID, intubation happens when you are required greater than 15 liters a minute to keep your sats above 93%, require high flow nasal cannula greater than 40 to 50 liters per minute with greater than 60% FiO2 on high flow nasal cannula, or you have maxed out your venturi face mask to keep your O2 sats above 92 to 95%. Also, too, making sure that it is a holistic approach to intubating a patient. If someone is not protecting their airway or they have a Glasgow coma scale less than 8, that would also be an indication for intubation. Intubation considerations. So intubation should generally be done by the most experienced provider present in the room or that can get there. Consider use of advanced technologies such as video-assisted laryngoscope to reduce the amount of aerosolization during intubation to the provider that is performing the intubation, and the fetal status may temporarily become non-reassuring with induction of anesthesia or intubation. Many times, especially in severe critical illness, patients can become hypoxemic or hypotensive with intubation. And so again, the need for mechanical ventilation or intubation is not reason alone to deliver a pregnant patient. Also, too, all providers in the room should wear PPE. And if for some reason a provider cannot get the airway or cannot see, they should not take off their PPE to get a better view. I can't stress that enough. And if you are at a hospital that has a COVID intubation team, utilize them. They're there not to only protect the patients, but to also protect you. Critical disease usually requires ICU admission if there is ICU space available. The vital signs are done in general every 1 to 2 hours with continuous telemetry, continuous pulse oximetry, and continuous temperature monitoring. Many times if a patient makes it to the ICU and they're on mechanical ventilation, there will be some form of non-invasive or invasive cardiac monitoring, and that can be very institution or ICU or even provider specific. Again, the type of monitoring that's done, whether it's invasive or non-invasive, is again dependent on the intensivist or the anesthesiologist taking care of that patient at that time.
So this is the algorithm that we put together in the document. Just wanted to present it at first so they can kind of see the overall flow, and then we'll go to this is the upper portion. So it starts with a hospitalized patient. So these are all admitted patients with COVID-19. And the first box is looking at worsening of symptoms. So if they're having a greater difficulty maintaining their oxygenation, even with supplemental oxygen, or if they're hypotensive, and we define this in this algorithm as a mean arterial pressure less than 65, despite appropriate fluid resuscitation, it's approximately ½ a liter to 1 liter of crystalloid fluids in general, then those are certainly concerning for worsening clinical status. An interesting point with COVID-19 patients is because they do seem to have significant pulmonary edema, clinical picture to a degree with ARDS, we're trying to maximize a conservative fluid strategy and have a judicious use of the fluids they do need, while also making sure we don't give them too much. So that needs to be borne in mind, that a bolus is appropriate to try and attempt to initially treat hypotension, but ongoing boluses may become less advantageous for these patients. And certainly if they have evidence of new end organ dysfunction, altered mental status, renal or hepatic insufficiency, or cardiac dysfunction, those are all indications for further escalations in care. If you have none of the above, these patients can maintain their current inpatient management and frequent reassessment. Ideally, that's where most of our patients will stay. If they have any of the above, the first response we recommend is consulting the intensivist and critical care team at your institution. Even if you don't have a team in-house, contacting whoever is on call or whoever is the hotline for your hospital system to gain some insights from our intensivist colleagues about what interventions may be available and maneuvers that may be employed to stave off further critical needs for these patients is our current recommendation. However, if a patient does have persistence of any of the above symptoms we discussed, as well as an increase or an inability to increase frequency of assessments, that is, you need to transfer them to a higher level of care, certainly if they become intubated or if they have definite evidence of end organ dysfunction that requires support, those are reasons to have the intensivist critical care team involved, and it would flow to the bottom right in the algorithm where they should be admitted to the intensive care unit and managed collaboratively with the intensivist critical care team. If none of the above is involved, those patients typically would be in an intermediate level care or step down, quote unquote, unit with certainly significantly low threshold for further escalation as needed.
So one thing that we really want to stress with COVID-19 is that a lot of the treatment is supportive in nature. So really great monitoring, really great multidisciplinary actions, and mechanical ventilation and supportive oxygen therapy if needed. However, in saying that, there are treatment options that are emerging. There are ongoing clinical trials with pharmacologic treatment in the non-pregnant populations, and these include hydroxychloroquine, azithromycin, remdesivir, tocilizumab, vaccines, and convalescent plasma. We want to stress that in the setting of COVID-19, none of these medications or vaccines are contraindicated in pregnancy. If, in saying that, we do recognize that many times exclusion criteria for clinical trials is pregnancy. So if that is the case at your institution, it would be a good idea to inquire about compassionate use protocols at your hospital or your institution. And usually that inquires either talking to your institution's institutional review board or the Pharmacy and Therapeutics Committee or P&T committees. And again, although most COVID-19 treatment clinical trials currently do not allow enrollment of pregnant patients, the SMFM advocates for inclusion of these patients in this critical population. So to talk about other considerations in COVID ICU patients, we wanted to talk about a few other topics that have come up. So one is secondary hemophagocytic lymphohistiocytosis or cytokine storm syndrome, or what I'll be referring to as SHLH, antibiotic use, anticoagulation, medications, effects, and potential complications, prone positioning, and delivery timing. So here is the SHLH scoring system. And this was put in the guidance really for more of exposure to our high-risk obstetric colleagues and obstetric providers. This is a scoring system that has gotten a lot of popularity with COVID-19, and it really focuses on things such as temperature, organomegaly, number of cytopenias, hypertriglyceridemia, fibrinogen level, ferritin level, and things of that nature to have a scoring system to see what is the likelihood of a patient having SHLH or cytokine storm syndrome. I want to be clear, we're not advocating that every pregnant patient that is positive with COVID-19 get a bone marrow biopsy. That is not what we're saying. But if you have a patient that has unremitting fevers that was at home and she comes in and she's like, I've been taking Tylenol around the clock as prescribed and my temperature continues to be at 39.0, it might be a good test to order in the presence of an intensivist or ID doctor or intensivist that is used to using the scoring system. It may help you decide whether you send that patient back home or whether you keep them for observation. Some of the inquisitive feedback that we've gotten is the fact that triglyceride levels are elevated in pregnancy, which is true. The median triglyceride level in pregnancy can be as high as 200 to 250, and that can be completely normal. But let's just say you did the scoring system for a patient that had unremitting fever. Even if she had unremitting fever and a high triglyceride level, that would put her at 97 points, which would still have her at less than 1% for having cytokine storm syndrome or SHLH. So again, we just want to say that it's more of a scoring system or more of like exposure, because this is what the critical care community is talking about. QT prolonging agents is also something that have kind of come to the forefront in the setting of COVID-19. Not necessarily because that we're using QT prolonging agents, but because of the fact that we are using, or that there has been use of hydroxychloroquine and azithromycin in clinical trials and in not in a non-clinical trial setting. If these medications are to be used, especially in the outpatient setting, a very detailed medication history should be done. So we should be looking at what type of medications that they're on, whether they're antipsychotics, antiarrhythmics, and antibiotics. Also of note, Pitocin or oxytocin itself can prolong the QT. So when a patient is placed on one of these medications, such as azithromycin or hydroxychloroquine, it's probably a good idea to get a baseline EKG to see if they have an underdiagnosed QTC prolongation or if one of their medications is causing QTC prolongation. When it comes to antibiotic therapy, a lot of times practitioners in the critical care community are concerned that there is a superimposed community-acquired pneumonia on top of COVID-19 infection, which is incredibly reasonable to think. Many times in the non-pregnant situation, ceftriaxone and azithromycin are used to treat community-acquired pneumonia, and these medications are not contraindicated in pregnancy. If you are to use antibiotics, you certainly should if you think that it's indicated. But just make sure that you are getting the culture data before starting the antibiotics, if that's possible. And you shouldn't wait longer than 45 minutes. Patients with COVID-19, it's a very long, protracted disease. And if someone's mechanically ventilated for longer than a week, they are certainly at risk for having ventilator-associated pneumonias and multi-drug-resistant pneumonias while being in the hospital while ventilated. Cefepime, meropenem, piptazo, or piperacillin, tazobactam, linezolid, and vancomycin are all considered broad-spectrum antibiotics, and these are acceptable in pregnancy, especially for MDR pneumonia. Procalcitonin has becoming popular even outside of COVID, is getting more popularity in COVID-19. I want to be clear that an elevated procalcitonin level does not exclude COVID-19 infection. However, in saying that, a lot of the studies from Wuhan, China, Italy, and France have shown that patients with COVID-19 often will have a normal procalcitonin level, which is less than 0.1 nanograms per milliliter. If you are concerned that someone has a superimposed bacterial infection because they have an elevated procalcitonin level with COVID-19, it is certainly reasonable to investigate that by getting further imaging, culture data, and starting antibiotics if indicated.
Anticoagulation has certainly been a topic of a lot of discussion recently, as these patients seem to have an increased risk, certainly for their coagulation factors, and they may have an increased risk for frank thrombosis. It's a little less clear if that is an aspect of the inflammatory and immune response process, or if that is a separate and individual driver of morbidity and mortality for these patients. Regardless, we do believe that patients who are admitted to the hospital, prophylactic anticoagulation is reasonable, unless there is an otherwise indication for full dose anticoagulation, such as a confirmed venous thromboembolism, DVT, or PE. Full anticoagulation approaches should be individualized with each institution, with the current practice and protocols, as well as with each individual patient. Some institutions are utilizing not only clinical and or biomarker criteria on some of the earlier scoring systems we discussed to determine which patients get full anticoagulation versus intermediate level versus prophylactic. And we recommend deferring to each institution's current protocols for those concerns. We do know there's an approximately 2 to 3-fold increased risk for preterm birth with inflammatory illnesses in general and systemic inflammation, whether that's spontaneous or iatrogenic birth. And we know that pregnant patients that have that increased risk, if they're on full dose anticoagulation, are going to have an increased risk for bleeding, and we need to be mindful of that as we manage them. For therapeutic anticoagulation in these critically ill pregnant patients, we do recommend unfractionated heparin due to its short half-life and easy reversibility with protamine sulfate. Standardized protocols at each institution for not only the infusion, but how the infusion may be titrated, stopped, or otherwise mitigated as needed for delivery should be known and utilized. The potential risks, as we discuss, with currently the unproven theoretical benefits specifically for COVID patients, also should be an informed consent discussion with the patient if feasible, if not with the patient because of altered mental status or sedation, certainly with their healthcare decision maker, and obviously subsequently documented thoroughly. If a heparin infusion is used, clinicians should recommend, or we recommend clinicians follow their institutional protocols, either following an APTT or anti-10A monitoring to achieve therapeutic effect. For patients receiving prophylactic dosing, low molecular weight heparin may be more beneficial for ease of once daily dosing to limit exposures to healthcare personnel. For patients on unfractionated heparin who develop a new onset thrombocytopenia, we also need to remember that the etiology of HIT could be the cause for this in these patients. The 4T scoring system can help assess if HIT is the etiology potentially for the thrombocytopenia, or it might be something else. As you may recall, the points are assigned 0 to 2, each for thrombocytopenia itself, for the timing thereof, for thrombosis or other sequelae, or if there's other evidence for other etiologies of thrombocytopenia.
And, Torre, I really love what you said about anticoagulation, and I like that you touched on even intermediate anticoagulation. A lot of, inquisitive feedback that we've gotten is, what do we do for patients that are asymptomatic or mild carriers that for their anticoagulation? Do we just do prophylactic, or do we bump them up to this more high intensity or intermediate anticoagulation before going to therapeutic? And just kind of going through the data, and the critically ill COVID-19 patients, if you look at the studies that are coming out of Wuhan, China, France, and Italy, they're quoting a 20 to 25% prevalence of thrombotic complications, whether it's VTE, stroke, or pulmonary embolism. Now, that's in the critically ill population. So I think we can all sit with the fact that, if a pregnant woman is critically ill, putting her, and she's not at risk of preterm birth, putting her on that intermediate or high intensity dosing of a low molecular weight heparin per that institution protocol is reasonable. However, a lot of LNDs are going towards testing all patients that are getting admitted to LND, whether that's to their antepartum units or for delivery. And so really the question happens, okay, so what do we do with the patient that is COVID-19 positive, that's just here for her C-section, and she's an asymptomatic carrier? There's not a lot of data on that. There are some very, very small case series that have shown that patients with COVID-19 that are not pregnant, the prevalence of thrombotic complications was about 3.6%. But again, this was in one paper, and it's, still not, what I mean? Like, you can't base your data off of one paper. But again, even in that situation, if bleeding risk is low, they're postpartum, they had a C-section for an obstetric indication, it is not unreasonable to go by your institutional guidelines for putting them on that intermediate or high intensity dosing, as long as you feel that bleeding complications are low. But again, I'm just going to urge you, it's an open conversation and a multidisciplinary conversation with your institution and the people that made that institutional protocol. So making sure that MFMs and OBs are involved in that process for deciding anticoagulation therapy is so imperative and important.
Prone positioning, also a hot topic in the critical care world for COVID and as well potentially for pregnant patients, as is this feasible has been discussed. It is feasible and it has been done and has been reported certainly in pregnant patients. It may be more challenging, and we recognize that and understand that. And that should be a discussion had with our intensivist colleagues for a pregnant patient who is currently intubated in the ICU about if the possibility of prone positioning can be accomplished for her in that unit and planning for it in advance. But this is feasible not only in pregnant as well as immediately postpartum recently delivered patients. Utilizing padding or support devices as needed, including OR padding and support, certainly to help position the patient properly, are certainly reasonable. And the most important aspect of this maneuver in pregnant patients as well as in non-pregnant patients is ensuring that the airway stays secure and the endotracheal tube does not become lost or malpositioned during rotation as well as afterwards. This is two obviously not pregnant patients, however, just to illustrate what prone positioning looks like. The patient on the right, however, you can notice that there is some padding around that patient, and we could utilize similar structures to help with our pregnant patients, even up through the third trimester, with the idea being the patient should be lying flat in an ideal situation and utilizing the padding as needed to accomplish that. This is a little bit of the physiology of why we believe prone positioning helps. On the schematic on the left, the two top pictures are patient in the supine position with the circles representing airways and the terminal alveoli. You can see most are compressed. Most of the circles are squished in those pictures. However, the bottom two in the schematic where the patient is lying in the prone position on their stomach, you can see those alveoli and airways are more open, and so they're able to participate in ventilation more efficiently. On the right, we see the same thing, however, on CT imaging over the course of several days of a patient being in the prone position and then reverse back to being supine for a few hours a day and then put back in the prone position. And you can see for this patient, they seem to have an improvement in their aeratable lung, as you can see, with much less of the ground glass opacities that you see in the left side of the CT image as compared to the right. Now we'll turn it over to Dr. Srinivas for delivery timing and onward.
Hey, thank you, Tori and Jason. And just I'll throw in one word about prone positioning, just from I think when you look at those pictures, if you haven't actually had to prone a pregnant patient, it's sort of the practical, or just like how to actually do that can seem sort of hard to imagine. And we've actually proned a couple of pregnant patients at this point in the 3rd trimester, and we've actually used, if you don't have padding, I think a couple of pearls that we've learned is the multidisciplinary conversation with the ICU team, which I think Jason and Tori touched upon for a lot of different things, is like critical. We actually kind of walked through the proning and exactly how that was going to happen, exactly how many people were needed. So the planning for it was even, I think, more time intensive than the actual act of proning. And then it was actually kind of 2 rolls that were made with almost like just like hospital blankets, that for our pregnant patients that were sort of in the 26 to 29 week gestational age frame, underneath them sort of in the chest area, and then again underneath them in sort of the mid quad area. And we were able to achieve no pressure on the gravid abdomen at all. And they were each proned for anywhere from like 16 to 20 hours and then were flipped back. So it's definitely possible to do even if you don't have like special padding, but with just like rolls and just sort of, if you think about putting that underneath the chest and then underneath the legs, you can kind of lift the patient enough to sort of not have any pressure on the belly. And it was pretty amazing how much they responded to proning, sort of based on the physiology that you just saw from those scans. Another huge topic of conversation has been around delivery timing. And we'll first talk about sort of asymptomatic or mild disease. And, COVID-19 status in and of itself is really not an indication for delivery without other just normal obstetrical indications. And particularly sort of in that 37 to 38 and 6 week range. You can certainly consider expectant management in that time frame until they're 14 days after a positive test result, or 7 days after onset of symptoms and 3 days after resolution of symptoms. And that might allow for a decreased exposure of healthcare workers and the neonate, as well as decreased PPE utilization in areas with supply chain limitations. And really, I think one of the important things to remember is, while it's not an indication for delivery, sort of all of the things we talked about earlier in terms of sort of monitoring patients and the knowledge that, the vast majority of patients are going to be mild and will not require hospitalization or sort of worsen in their symptoms, but some percentage of patients, pregnant patients included, on that day 7 to 9 or so will get worse. And so monitoring of these patients and some is very important in terms of figuring out. And so I think it's really hard to come up with a specific, in every scenario, this is exactly what needs to happen. But in general, COVID-19 shouldn't be a reason for an indication for delivery, but monitoring of patients. And if there's some percentage of patients that are getting worse in that time frame, then that decision has to be individualized for that patient based on their symptoms and the gestational age that they're at. You guys can flip the slide. At 39 weeks of gestation, delivery can be considered to decrease the risk of worsening maternal status. So it's sort of a risk-benefit balance in terms of the gestational age that you're at and the chance that worsening could happen, and how you're weighing those things. And certainly mode of delivery should remain per routine indication. And during delivery, any COVID-19 patient should be instructed to wear a mask through labor and delivery and postpartum, and appropriate PPE should be utilized by all caring for such patients. And, I think this has come up just practically speaking for all of us that have, I think, delivered COVID positive patients. Just, it's really hard for patients to push in the second stage with a mask on. And so I've heard of some different sort of unique fixes to that from different people. One being, some people have sort of put up two IV poles in a delivery room and actually put up sort of a clear drape. So for those of us have clear drapes for C-sections, putting up a clear drape so that a mask doesn't have to be worn, but there's a barrier if a patient's sort of like breathing, coughing, all of those things, as just another way, because I think wearing a mask for some patients that are pushing it can be difficult. So I think through this, we've all kind of developed some unique fixes to some of the more practical considerations as we are learning more, as we take care of more people. Next slide. In critical patients, timing of delivery should definitely be individualized, as Jason and Tori said earlier, for many of the other decisions. And the decisions are based on maternal status and pulmonary disease that's concurrent, ability to wean off the ventilator and ventilator mechanics, gestational age, and then of course shared decision-making with the patient or healthcare proxy. Some of the patients that I mentioned earlier, just in terms of experience with proning and decision-making, we've seen some patients take a little bit longer to really recover, and every couple of days it's really kind of a decision and discussion around risk benefit in terms of how sick the patient is, whether a surgery could be more harmful than beneficial. Will delivery actually help ventilator mechanics? Like, are the ventilator mechanics about ventilation or oxygenation? What's really seemingly going on? And even some of that cytokine storm, and really seeing how these patients can be persistently febrile, and really just balancing for every patient. And this decision and discussion has been different for every patient in terms of some patients, we've had some patients who have actually, slowly, methodically sort of gotten better, but once they hit sort of that 30 to 32 week mark, feeling like it's unclear whether sometimes some of these very critically ill patients might get worse, and maybe delivery, when there's a kind of a window of time when they're actually pretty stable and you've hit a gestational age that seems reasonable, might be a good decision for that patient. Whereas that might not be the same decision that you might make at, an earlier gestational age, like at 26 or 27 weeks. So all of these, I think the tenets and the framework of the conversation is sort of driven by the same principles, but the decision making is really dependent on every individual patient in these multidisciplinary conversations with your critical care teams as well. Next slide. And again, sort of improvement in lung mechanics gained by an early delivery is really theoretical. Sort of in the third trimester, the pressure of the uterus can decrease expiratory reserve volume, inspiratory reserve volume, functional residual capacity, and that can increase the risk of severe hypoxemia. But again, how much delivery is going to help is really dependent on what really is making that patient sicker at that time and the gestational age of that patient. And so while there is some data regarding delivery timing and acute respiratory distress syndrome, it's very limited. So again, every patient, these are just the principles that we sort of think about and talk through with every individual patient in really close communication with our critical care teams. And I think with each one of these patients that we've cared for, it's been, again, all of those same conversations, but the decision-making has actually been very different depending on each patient. Next slide. And in critical disease patients, disease progression can be protracted, and mechanical ventilation alone is not an indication for delivery. I think that, again, it's these, when you hit sort of that 30 to 32 week mark, it's important to sort of, if you're earlier than that, considering some of the things that we just talked about, like prone positioning, ECMO, other advanced ventilator methods, especially in pretty early gestational ages, as you're sort of weighing the likelihood of being able to support, as Jason and Tori said, supportive management is really the most important thing for these patients. Can we support patients through recovery without delivery, or is delivery really going to help improve the respiratory mechanics? But I will say that one thing that was really helpful in sort of talking with our critical care colleagues about in the sort of several ICU patients we've had is the fact that, while our patients were very sick, it was very clear from talking to them that they weren't any sicker or responding or progressing in improvement any differently than the non-pregnant patients. And so with each discussion, it was sort of this question of whether pregnancy was in some way hindering their recovery. And as we kind of worked through this together, it seemed like from their perspective that our patients, although as sick as they were sort of as sick as the other non-pregnant patients, and their recovery actually was sort of mirroring that of the non-pregnant population as well, despite continuing the physiology and the impact of being pregnant on some of the respiratory mechanics. A couple of other quick miscellaneous, and then we want to really get to questions. There's really limited data on fetal risks. There's no evidence of fetal transmission. And really, there's like some growing concern out there about kind of potential association with intrauterine fetal demise. We really don't know that to be the case. And there's not really clear evidence for that. And I think there's always also the indirect impact of all of the changes we're making to care with COVID-19 in our individual practices, and just sort of the direct impact of COVID and also the indirect impact with care changes. And so right now we're recommending that antenatal surveillance for the usual obstetrical indications and, testing per your local protocols. And, at some point as we get more information that might change, but as far as we know now, that's the current, what we know currently. In terms of the clinical question of intrapartum or postpartum fever without a clear cause, this is one I think that comes up quite a bit for people. And so, how much do you kind of worry that a fever that you can't clearly explain by another cause can be, is potentially COVID? And we're really recommending that, if the fever is unexplained, during labor or immediately postpartum, that it should be evaluated as usual, and that COVID screening and testing according to your institutional policy and guidelines should be considered. So if you have a patient that I think clinically wasn't ruptured for very long, had a precipitous labor, and then is febrile and maybe has some other symptoms, that might make sense to test for COVID. But another patient that has clear symptoms for something else where you're pretty clear on the diagnosis may not need to be tested. So I think using our clinical judgment, of course, and some of your laxity around testing might change based on, or how you approach this might change based on sort of what your institutional policy and guidelines are for testing. Next slide. Preterm delivery has definitely been reported among infants born to women positive for COVID-19, but it seems to be largely medically indicated and non-spontaneous. So when we're just talking about some of these critically ill patients, all of those patients largely will be delivered or are delivered preterm, depending on when they're presenting and how sick they are. And other severe systemic illnesses also appear to increase the risk of preterm birth by 2 to 3-fold. Magnesium sulfate for neuroprotection should be individualized. It's of course reasonable to consider withholding or dose adjusting if you have concurrent acute renal injury. It's unclear whether MAG increases the risk of pulmonary edema, and obviously if your patients are intubated or already having oxygenation issues, maybe that's not a great choice. So really kind of weighing again risks and benefits, gestational age, of how important that might be for that individual patient. And finally, preeclampsia, laboratory findings can definitely overlap with those found in HELLP syndrome. But the diagnostic criteria for preeclampsia really remain unchanged. And it's reasonable to consider, testing for COVID-19 if a patient has transaminitis, thrombocytopenia, other risk factors, maybe even renal injury. We had a recent patient that at a very early late second trimester gestational age had what seemed like preeclampsia, but pulmonary edema, acute renal injury, also was positive for COVID and was tested because of these overlapping presenting issues with pretty severely elevated blood pressures. So we ended up, really trying to get some more information, trending a few labs, giving some steroids, and then eventually it really seemed like preeclampsia, and we delivered that patient as we normally would, and things got better. But I think it can be very clinically challenging. And just making sure, just remembering that there is overlap, and as many things as we can do to try to get some more information with trending different labs, and but also not forgetting that sometimes preeclampsia cannot be expectantly managed, and when it and delivery in those situations can really improve the clinical status of a patient. Lastly, antenatal steroids have been maybe associated with potential worsening of pulmonary status and viral shedding in other respiratory illnesses. Again, use for risk benefit in terms of kind of how sick the patient is, whether steroids would really be necessary. The upper limit of, using the upper limit of 34 weeks and really thinking about moderate to severe pulmonary manifestations, that the benefit of late preterm steroids may not outweigh the potential risks. In some of our critically ill patients, the ICU team has been giving high dose steroids for other like hemodynamic reasons. And if that's the case, sometimes you can overlap those steroids and, use dexamethasone as your, for that indication, and also achieve lung maturity with that. So that's sort of another thing that we've come across. And finally, timing of thromboprophylaxis. I think this was already touched upon, but individual institutional guidelines, and it varies by illness severity. But generally, I think there's not clear guidance for these non-critically ill patients, and prophylaxis, particularly, I think Jason or Tori brought up the asymptomatic population and patients who are asymptomatic and positive, whether they really have the same thrombotic risk that we're seeing in some of the other severe and critically ill patients. I know we have a few minutes left, and I think Audrey, you're moderating. We'd love to get some questions in there.
So I think some of them have been answered. I think right now we have kind of two groups. There's some anticoagulation questions that we'll start with. The first one is, what's the role of continuation of anticoagulation on an outpatient basis after discharge in moderate to severe patients? And if so, for what duration?
So that is an excellent question. I would say a lot of the patients that get critical disease or severe disease have really extensive lung involvement. And some of these patients do go to a rehab facility because they are immobile. And some of these patients, because of their increased risk factors and their critical illness, are on prophylactic anticoagulation. There really is not a lot of guidance of when to stop that anticoagulation. There's really not, and there's especially not a lot of guidance in the pregnant population. I would say if you have a mom who was prone, mechanically ventilated for 2 to 3 weeks, and will need to go to a pulmonary rehab facility to get better, and you don't have a real fear for going into preterm labor at this point, I think it is an incredibly reasonable to place her on prophylactic low molecular weight heparin, especially if she has a BMI greater than 40, or she has other risk factors, or if she is a factor 5 Leiden carrier and her mom had a PE. No one is going to argue with you putting them on low molecular weight heparin. The real question is, for the mild symptoms and for the asymptomatic individuals, do we start prophylactic anticoagulation on those patients on the outpatient setting? And right now, I think that there's not enough data to say that you need to do that. Again, look at patient risk factors. A lot of patients that have COVID-19 that have mild symptoms may have a D-dimer level that's certainly greater than 1.5 or 2, the upper limits of normal. So again, if that patient, you did their C-section, their bleeding is normal, and you want to send them home on anticoagulation because they have additional risk factors, I think that that's reasonable, but I think it really needs to be on a patient by patient or individualized basis.
Great, thank you, Jason. Next question is for the use of aspirin to prevent CVA, potentially in patients that aren't already receiving aspirin for other reasons.
Yeah, this is Torre Halscott. I think it's a great question. I think the short answer is we're not sure how beneficial that may be for COVID patients, specifically from a thromboprophylaxis standpoint. We would, at this point, recommend utilizing aspirin for the common obstetrical indications, as well as for other medical indications if they are already coming to pregnancy on low-dose aspirin, and otherwise deferring until there's more information and literature to support utilizing it specifically for COVID.
Great, thank you. looking at some of the other questions. There's been a bunch of questions about prone positioning and continuous fetal monitoring, which I think Dr. Srinivas answered. I don't know if you have any further comments on that, or monitoring, or what happens if an urgent delivery is needed when a patient is prone.
I was just going to say, and Troy and Jason might have other comments about that. I mean, I think if someone's being proned, they're pretty sick. And so the decision about sort of a delivery in somebody who's that critically ill and the impact that might have on the mom herself needs to be considered when you're sort of thinking about whether we would be monitoring continuously during that time. We didn't, for our patients that were being proned, we did not monitor them while they were prone. We sort of had checked on the fetus prior to proning and then afterwards, but we didn't monitor during. And the proning for one patient was about pretty much around 16 hours was around the time, the amount of time we proned these patients. I think one sort of a lower end of 14 and an upper end of 20. And we talked through sort of what if an urgent delivery is needed. So at the time you're proning a patient, there can be sort of an intolerance of the proning in terms of cardiovascularly. And so we sort of talked through that before the proning actually happened and had sort of everything available. But remember, you definitely need to ensure that everyone going into the room is wearing the right PPE and that it's safe for all of the providers that are kind of caring for the patient. So it's sort of urgent, couched with urgent with appropriate PPE usage. I don't know, Jason or Tori, if you have any comments about that.
Yeah, no, certainly, yeah, we agree, with the statements. I think a lot of it depends on the gestational age for the patient and the other clinical factors. Dr. Srinivas was saying it's a complicated and ongoing discussion, but certainly one that needs to be had ideally before the occurrence of indications for proning, so that there's a plan in place. If continuous monitoring is decided upon, I try to be pretty simple with things myself. I would use an ultrasound to find the closest point to the fetal heart rate, and I would place the monitor there and put the straps on tightly. These patients are intubated, sedated, have pain management as needed, and that way you can ideally, after you rotate them, still have the monitor in a good place if that's going to be utilized, with the caveat as well, if you're going to be monitoring, having a plan about what to do with that information and how you're going to logistically intervene upon it is of paramount importance.
Great, thank you. I think one of the other themes that we're seeing is about ventilation for these patients, particularly supplemental oxygen by nasal cannula versus mask, and is there a concern for aerosolizing when the flow rate exceeds the patient's minute ventilation?
Yeah, I think it's a great question, and certainly it's a concern. How much aerosolization does occur? I don't know that we know greatly in these patients. I think a lot has to do with how well the supplemental oxygen device is being utilized. A nasal cannula in the proper position is going to have less spread than a nasal cannula that is malpositioned. Same thing with a face mask or a BiPAP or CPAP mask. So those things need to be made mindful of when we're utilizing these. And I think the potentially bigger picture with those concerns is that if a patient is exceeding or has a very high flow rate, we need to think about, is this patient okay to not remain intubated? And do we need to then escalate and give them a more definitive airway, which also provides the benefit of decreasing that risk of aerosolization at that point?
Great, thank you. I think we'll do one more question, and this is on, are there any prediction models for progression to severe disease that have been shown in pregnancy, particularly some of the things that people have been following in COVID, like CRP, ferritin, D-dimer, any of that?
Yeah, so that's a really great question as well. I think one thing that we're seeing with COVID-19 is the bimodal effect of the disease. So someone will contract the disease, they'll have febrile morbidity, and then they might be on the mend or feeling like they're getting better, and then they will all of a sudden just have this crash and burn critical illness. And I think that's where the SHLH system, or the cytokine storm syndrome scoring system, kind of comes into place. There have been a lot of prediction models that are trying to be developed in non-pregnant, so following CRPs, like if the CRP is starting to elevate again, if the ferritin's starting to elevate again, or if there's new onset lymphopenia that was once improving, those can be signs of worsening illness or worsening ARDS. However, none of these models have been shown in pregnancy. And the reason is number one, we don't know, we're not testing really asymptomatic individuals with these labs, or individuals that are not admitted. And then number two, we don't have all the numbers yet specifically for pregnancy to say definitively, is this going to happen? I would say if someone is sick enough to get those labs, again, I can't urge enough that it's probably a good idea to make sure that there is a provider, whether it's an MFM, an intensivist, an OB anesthesiologist, that is following along to kind of say, okay, the CRP went from 5 to 15, and you're like, something, and the patient's more febrile, something is going on. I will say, as these inflammatory markers go up, the patients will show that they're doing worse clinically. So again, a holistic approach is needed. And if you're fearful that your patient is getting worse, it's definitely okay to transition them to a higher level of care or a lateral transfer to another hospital that can.
Great, thank you so much. Dr. Srinivas, you wanted to comment on one thing?
One other thing. Just another sort of thing that I wanted to mention, because we didn't totally touch on it, but for these really critically ill patients, mental health support and just, especially for patients that have been intubated in the ICU, and I know this sort of probably goes without saying for any condition, and that we care for patients and not just COVID, but other kind of critically ill situations. But some of the, just how prolonged the course can be, and the fact that a lot of these babies are preterm and in the ICN afterwards, just sort of the mental health aspects for the patient and sort of coping when they go home has been something that has kind of come up quite a bit, and providing support, especially in a time right now where in-person sort of visits and just sort of coming up with unique ways to provide that support has been critical. And just sort of also considering sort of before patients go home, a lot of these patients who've been in the ICU may not have met their baby after delivery yet, depending on sort of what situation they've been in, how much longer they were intubated, et cetera. And so our ICN and many RCNs are using sort of a 2 negative policy for before visitation can happen. So just sort of thinking about that as well and sort of facilitating that in terms of the importance for our patients as well in their recovery.
Great, definitely a good point to end on. Thank you so much, everybody, for attending. We hope this was helpful. The recording will be up on the website, and have a great afternoon.
Thank you.
Thank you so much.
Thanks all.